Rheumatoid arthritis is a chronic systemic and autoimmune disease with a variable clinical symptoms, characterized by a mild to severe inflammation of the joints that can result in joint pain, dryness, and destruction along with joint malformation and disability. Its etiology is unknown, and its pathogenesis involves mechanisms that alter the immune response. Causes of rheumatoid arthritis. The causes of rheumatoid arthritis are not yet known with certainty. What is known is that genetic factors are involved in its origins, as well as non-genetic factors. The non-genetic factors are not well known either, but we can find infections. This theory is based on the fact that in some cases, rheumatoid arthritis appears in infectious diseases.
It is classified as chronic autoimmune disorder that mainly affects the synovial joints, destroys the articular cartilage, and reduces the proliferate. An inflammatory not supported synovirus. It also causes extra-articular lesion to the inflammatory process. It can affect various organs, such as the skin, heart, blood vessels, and lungs, leading to the secondary clinical manifestation, such as systemic lupus erythematosus. It affects the population of a race and has a universal distribution.
Its prevalence in the adult population is 0.5% to 1%. The annual incidence is 8 to 15 new cases per 100,000 inhabitants and affects more women. It can start at any time in life. It is peak incidence being between 30 and 60 years. Rheumatoid arthritis is a public health problem due to its prevalence, functional consequences, socioeconomic impact, and greater use of health service. The mortality reported is patients with rheumatoid arthritis is higher than in general population, with a standardized rate of 2.26, showing a reduction in her life expectancy.
Rheumatoid arthritis usually affect the joints symmetrically, but is not always the case. The main symptoms of rheumatoid arthritis are joint pain, unstable and painful. It usually worse in the morning after a period of inactivity. Stainless affect joints often feel stiff, swelling, wound, and redness. And additional symptoms, more general, are fever, weight loss, and lack of appetite, and tiredness, and lack of energy.
The symptoms in patients with arthritis can be classified into in systemic and articulary. The systemic symptoms, such as fatigue, low fever, and weight loss, usually appear before joint symptoms. Early joint symptoms usually appear in the hands, in the wrists, and feet, beginning with swelling and pain in the metacarpophalangeal, proximal interphalangeal, and metatarsophalangeal joints. In a general, very characteristic symptom is the loss of muscular strength because the patient tend to drop objects or can't hold them due to pain, swelling, and secondary weakness due to muscular atrophy. In addition to loss of function due to synovial inflammation and rupture of the membrane, as well the extensor tendon. Symptoms according to body regions. In the hands and wrists, we find synovial thickening around the wrists, radial deviation in wrists, unual deviation, subcutaneous nodes. In the feet and ankles can see subluxation to the toes. This occurs only when the disease is very late. In elbows can see swelling, subcutaneous nodes, and synovial thickening. In the hips, there is a reduced the range of motion.
Treatments. Currently, there is no cure for RA. However, current treatment methods aim to relieve pain, reduce inflammation, stop or delay joint damage, as well as improve the patient's functions. Drug therapy forms the basis of treatment. Its objectives are to relieve symptoms, achieve the interruption of inflammatory activity, prevent the joint injuries, and avoid loss of joint function. The main drugs used in treatment are analgesics, non-steroidal anti-inflammatory drugs, corticosteroids, and traditional disease-modifying anti-rheumatic drugs. For example, for non-steroidal anti-inflammatory drugs, we have ibuprofen and ketoprofen. For disease-modifying anti-rheumatic drugs, we have methotrexate and sulfasalazine. TNF-alpha inhibitors, we have infliximab, and at least we have corticosteroids, for example, prednisone and methylprednisone.
If the use of medication and physical therapy does not help the patient to improve, the doctor will recommend that surgery be performed to repair damaged joints, correct deformities, and reduce the pain. The surgical procedures that can be performed are arthroplasty, which is procedure in which a total joint replacement is performed. The surgeon removes the damaged part and insert a metal or plastic prosthesis or an artificial joint. The tendon repair, this is because the rheumatoid arthritis can damage tendons around the joint that have become loose or torn. The surgery will help to restore them. The synovectomy, this procedure where the synovium will be removed, it is inflamed and painful. After this, the surgeon will fuse a bone or joint to decrease the pain and realign or stabilize the joint. The two bones that make up the joint are fused with screws or sometimes bone implants.
Pharmacology strategies. There are three general classes of drugs commonly used in the treatment of rheumatoid arthritis: non-steroidal anti-inflammatory agents, NSAIDs, corticosteroids, and disease-modifying anti-rheumatic drugs, DMARDs. NSAIDs, anticorticosteroids, have a short onset of action, while DMARDs can take several weeks or months to demonstrate a clinical effect. DMARDs include methotrexate, sulfasalazine, leflunomide. Other immunomodulators are occasionally used, including IC2 and cytosine, because cartilage, pneumonia, and bone erosion frequently occur within the first 2 years of disease. Rheumatologists now move aggressively to a DMARD agent early in the course of disease, usually as soon as a diagnosis is confirmed.
Prevention. These established productive models for fissure RA is the best prevention optional. The 2010 American College of Rheumatology and European League Against Rheumatism classification criteria enable the identification of patients into the preclinical phase or RA with a relapsed short duration of symptoms who may benefit for early treatment intervention. The precise identification of individuals at risk or future RA development, including those with genetic and environmental risk factors, RA-associated autoantibodies, clinical subpep, arthralgia, subclinical cyanovirus, and other factors may benefit to choose the right prevention at the right time.
With those references already mentioned, we can divide the prevention into 3 stages. First, primary prevention aims to prevent the risk from developing RA. This means to intervene during the asymptomatic phase of individuals with genetic or environmental risk factors, like lifestyle modifications such as smoking cessation, dietary changes, weight reduction, and good oral hygiene. Secondary prevention aims to early detect and reduce the impact of already present disease before it fully develops. Focus on individuals with symptoms without clinical arthritis. So in this stage, there is a therapeutic window of opportunity which the introduction of disease-modifying anti-rheumatic drugs or even glucocorticoids can protect against joint destruction, prevention of disability, and delay many symptoms. Finally, tertiary prevention aims to soften the impact of already established disease and improves patients' quality of life. So this prevention is only related to treatment.